So we move on to our final talk, and it's really my pleasure. So we have someone who is not a neurologist, so he's a cardiologist, but well, he's a neuromuscular cardiologist. There's only a very few of them, and Karim Baby from Paris is a very good colleague, has a lot of experience with neuromuscular patients, and as lung function and swallowing fatigue is all important, but if the heart is not working, no chance at all. So, Karim, prevent us. Thank you.
Thank you very much, Benedict. So I'm really happy to give this course on heart involvement in neuromuscular diseases. Here are my disclosures. So as an introduction, I would like to say that, to remind you that cardiac involvement is extremely frequent in patients with myopathies. It's also frequently severe, with a significant impact in many patients on life expectancy. Cardiac and respiratory complications remain the most frequent causes of death in patients with myopathies. And for that reason, having cardiac assessments done at diagnosis and during follow-up is extremely important. Firstly, because at initial diagnosis, since the cardiac patterns may be different from one disease to another, having cardiac manifestations can help for the etiological diagnosis. And then at baseline and during follow-up, it's important to identify cardiac abnormalities, to have a follow-up plan, and to offer patients prevention. And I will try to show you today how prevention can work in those patients and can really improve life expectancy. This is probably the most important message. You can see here on the right the echocardiogram of a patient with Duchenne muscular dystrophy, and on the left a normal echocardiogram. So you can see here normal heart pumping, and on the right the heart of DMD patients with an advanced dilated cardiomyopathy. Here you have a left ventricle with a diameter of 5 centimeters. Here you have a left ventricle with a diameter of more than 10 centimeters. I think you can easily figure out that it will be extremely challenging to treat these patients. At this stage, you have a lot of fibrosis everywhere, and you can give this patient any treatment you have, even exon skipping, gene therapy. Treatment can't be efficient. So you need to treat really patients early, and for that you need to have an early diagnosis. So firstly, I will go through some general aspects on neuromuscular cardiomyopathies, and then I will move on to some of the most frequent conditions at risk for severe cardiac involvement. So first of all, very basically, there are great similarities between the skeletal and the cardiac muscles, and that's the reason why you have in many conditions cardiac abnormalities that can be present. You have the prominent one gene, one protein paradigm, with many of the proteins in the sarcomere, in the cytoplasm, in the nuclear membrane present in these two tissues. You can see different patterns from one condition to another, with sometimes an involvement of the myocardium, sometimes abnormalities of the electrical system, sometimes both of them. And among cardiomyopathies, the most common one by far is dilated cardiomyopathy, which is defined by a reduced contractility of the cardiac muscle, which can be seen in many conditions. Hypertrophic cardiomyopathy can be seen as well, but it's far less prevalent, mainly in metabolic conditions, mitochondrial diseases, and other metabolic diseases. Restrictive cardiomyopathies is quite exceptional. We can see restrictive cardiomyopathies mainly in myofibrillar myopathies and such as desminopathies. Electrical abnormalities are also extremely common, sometimes isolated, and sometimes associated with dilated cardiomyopathy, And in that case, you have a specific subgroup of patients who have what we call arrhythmogenic cardiomyopathies, which are really at high risk for sudden death. Conduction system disease is very frequent in myotonic dystrophy and in other conditions. We'll see that. Ventricular tachyarrhythmias in arrhythmogenic cardiomyopathies and supraventricular arrhythmias are extremely common as well. Myocardial involvement can lead to heart failure, which represents a very common cause of death in neuromuscular patients. And electrical abnormalities represent a common cause of sudden death, either due to major conduction defects or severe ventricular tachyarrhythmias. And some patients can also have stroke due to atrial fibrillation. So we have several tools available as cardiologists for the characterization of neuromuscular abnormalities, very simple ones such as the ECG and the echo. And just with the ECG and the echo, you have a lot of information available, and you can make most of the most important decisions for patient follow-up and treatment. And then you have the possibility to use cardiac MRI. Cardiac MRI has an increasing role in the management of neuromuscular patients. It's probably more reliable than the echo, especially in patients who have chest deformations, respiratory failure, to monitor cardiac function. And very importantly, on top of the assessment of contractility and left ventricular ejection fraction, you also have access to tissue characterization. You can see here in the left ventricle in white, just follow the arrows, something white. This is what we call lead gadolinium enhancement. It corresponds generally to the presence of fibrosis, and sometimes fibrosis precedes cardiac dysfunction, and this is a very important information for the management of patients. Some blood biomarkers can also be useful to monitor heart failure, and sometimes you can use prolonged recordings, 24 hours alter ECG. Now we have recordings of several weeks, and we also have loop recorders, and patients can have a loop recorder in place for 3 years for very continuous monitoring of potential arrhythmias. What makes the management of neuromuscular cardiomyopathies really complex is the fact that you have very different patterns from one condition to another. There are some groups. I will try to present you some specific patterns with some specific management, but globally you have a huge diversity. But the good news is that in the majority of patients at initial diagnosis, in the continuum, the development of cardiac involvement from very early stages to very advanced cardiomyopathy with heart failure, sudden death, generally at initial diagnosis, patients have mild abnormalities in 90% of cases, which leaves space for prevention and positive impact on long-term prognosis. So I'll move on now to myotonic dystrophy type 1 as an example of a condition at high risk for sudden death due to conduction defects. The main problem in DM1 is the prevention of that, development of severe conduction defects, especially complete AV blocks, which represent the main cause of sudden death in this population, the prominent mechanism. Very basically, cardiac involvement in DM1 is a cardiac channelopathy, mainly related to an abnormal splicing of SCN5A, a gene encoding the cardiac sodium channel. And the main manifestations are electrical abnormalities in this population. And the most common one is conduction system defect in any areas, but atrioventricular conduction abnormalities are the most common. And the progression of AV conduction abnormalities to complete AV block represents the main cause of death. Some patients can also have ventricular arrhythmias, and some patients have ventricular tachycardia and can die due to ventricular tachycardia, but it's far less common. And supraventricular arrhythmias are also common in this population. The annual incidence of sudden death prior to all the prevention measures we currently use was probably 3 to 4% every year. Currently, the most recent data suggests that the area of prevention is between 0.5 and 1.2 or 1.5 every year. And some patients have stroke due to ventricular tachyarrhythmias, and some patients develop dilated cardiomyopathy, but it's not that common in patients with DM1. So the main problem is the management of electrical abnormalities and the prevention of sudden death, mainly due to major conduction defects. So very basically, you need to see patients at least on a yearly basis when patients have abnormalities, or perhaps every 2 years if all cardiac assessments are normal. And if you are in the situation where patients have conduction defects on the ECG, then you need to decide what you should do to reduce the risk for patients to die suddenly. When the ECG is normal, we know that the risk for sudden death is extremely low. In patients who have symptoms, syncope, and major conduction defects, obviously you have an indication for a pacemaker, but the problem is how to make decisions in the middle group, which represents at least 50% of patients. And in that situation, you need to estimate the risk for patients to die suddenly, and the only treatment you have available is the implantation of a pacemaker. So you have two approaches. The first, non-invasive approach based on ECG parameters, and the second approach is an invasive strategy based on electrophysiological study. Very basically, we know that patients with an abnormal ECG and sometimes abnormalities on the echo, history of atrial fibrillation, are at increased risk for sudden death. It's statistically significant, but the problem is that those criteria, which have been validated both in US and in Europe by our group, all those criteria have a low positive predictive value, which means that it's difficult to make the decision to implant a pacemaker solely on the ECG findings. Some groups still use this approach in the world, but not so many. Majority of groups use an invasive assessment of conduction parameters based on an electrical study, which requires generally hospitalization of half a day to 1 day. And the electrical study helps you characterizing more accurately conduction parameters and specifically determining if you have conduction delays located in the most critical areas at the highest risk for sudden death. It has been shown, for example, that one parameter called the HV interval, when it's prolonged at more than 70 milliseconds, you have 50% of patients who have major conduction defects during follow-up. So not all, but many centers worldwide systematically use the EP study when patients have an abnormal ECG. And 10 years ago, our group showed that using this systematic invasive approach has a positive impact on life expectancy. I told you that prevention works in neuromuscular patients. It's very important. And this study showed that patients managed invasively had better overall survival, mainly because they have a huge reduction in the risk for sudden death. So very basically, at baseline, you need to have at least an ECG and echo done. You need to repeat them every 1 to 2 years, according to, depending on the initial findings. And if at some point you have syncope, lightheadedness, or an abnormal ECG, then you should discuss an EP study. If the EP study is reassuring, you just need to continue follow-up. And if you have what we call inferential conduction abnormalities, then you need to implant a device. In the majority of cases, a pacemaker, and sometimes you can discuss a cardiac defibrillator in patients who have a history of ventricular tachycardia. And another aspect, I can present everything of the management of patients with DM1 in the prevention of thromboembolic complications, because some of those patients also die suddenly due to pulmonary embolism. So they are in situations at increased risk for deep venous thrombosis. You need to be proactive in the usage of thromboprophylaxis. I'll move on now to a second condition, which is also prevalent and at high risk for cardiac complications, which is Duchenne muscular dystrophy. And for DMD, the problem is completely different. These patients have quite low risk for some deaths, but a high risk to develop terminal heart failure. And I will show you that prevention also works for heart failure. Very basically, we know that DMD patients are at risk for dilated cardiomyopathy and severe heart failure, that the prevalence of dilated cardiomyopathy increases progressively after the age of 10 years, and that majority of adult patients have DCM. And we know that many deaths are a consequence in DMD patients of dilated cardiomyopathy and heart failure, approximately 40%. If you use cardiac MRI, you can even identify cardiac abnormalities earlier, before the age of 10 and even before the age of 8 years. You can find patients' evidence of myocardial fibrosis. So the high risk for patients to develop terminal, severe and sometimes terminal heart failure is a strong rationale for using prophylactic treatments. And you have now globally a consensus worldwide to support the use of prophylactic treatments to improve long-term outcomes in this population. Before using treatments, you need to have cardiac assessments done at diagnosis and repeated during follow-up. At diagnosis, it's important to have an ECG and an echo. The best is to have also an MRI done. In young kids, it can be a bit challenging, but after the age of 7 years, it's quite easily feasible. And then you need to repeat at least an ECG and an echo every year. And at some point, it could be useful to repeat cardiac MRI, but I think there's no consensus on how often it should be repeated, probably every 3 to 5 years. So you have this follow-up, and you need to implement prophylactic treatments. Firstly, you have the glucocorticoids, and then you have a number of medications that have been used in the general population to treat heart failure and who have proven beneficial in DMD as prophylactic treatments. The first one is ACE inhibitors. We have this randomized trial published in 2005 showing that treating young kids with DMD around the age of 10 years with ACE inhibitors reduced the risk for patients to have dilated cardiomyopathy at 5 years and improve their long-term outcomes with an improved overall survival at 10 years, mainly because patients have far less severe heart failures. More recently, we showed that in a real-life setting, based on the analysis of our French registry, we showed in hundreds of patients that we had really the same amount of benefit on overall survival with ACE inhibitors in hundreds of patients treated. There are a number of other heart failure medications. I can't go through all the treatments, but mainly you have eplerenone, which have proven beneficial in patients with evidence of mild fibrosis. It was a publication in Lancet Neurology. We have ongoing studies with beta blockers, which is also a major treatment of heart failure, without evidence to date of the benefit with beta blockers. So there's a number of treatments which can be implemented on top of ACE inhibitors. And as I told you, glucocorticoids are also beneficial at the myocardial level. We have no randomized trial, we'll never have, but we have a number of observational studies, retrospective and some prospective. I think the most interesting one is probably this one, showing that kids treated with glucocorticoids early had better long-term outcomes and less terminal heart failure. And a few words on patients with DMD, like the one I showed you on one of my first slides. When you have advanced heart failure, I think you need to have also a proactive management of patients and to implement all the cardiac treatments which are available. Sometimes in patients who have significant cardiac desynchrony with major conduction defects on ECG, you can discuss cardiac resynchronization therapy. Sometimes when you have severe cardiac dysfunction in patients who have moderate respiratory involvement, you can discuss the implantation of a cardiac defibrillator. And sometimes in patients with terminal heart failure, who are unfortunately not eligible for cardiac transplantation, you can discuss in highly selected patients on an individual basis the implantation of devices, what we call left ventricular assist devices, which is an internal cardiac pump. And with such devices, sometimes patients can live a normal life. So in a number of other conditions, patients are at risk for developing dilated cardiomyopathy and heart failure, especially in other dystrophinopathies, but also in some LGMDs, sarcoglycanopathies, in patients with FKRP variants. In that case, I think it's always important to consider the risk for patients to develop severe heart failure and to discuss prophylactic treatments such as ACE inhibitors when you have evidence of myocardial disease, even if you have only mild contractility abnormalities or mild fibrosis burden. I think it is worth discussing at least the indication of those treatments that are generally well tolerated. And finally, I will finish my talk with laminopathies and conditions at high risk for ventricular tachyarrhythmias and sudden death. While you know that laminopathies are conditions that may be associated with severe cardiac involvement, patients can have both dilated cardiomyopathies, supraventricular and ventricular tachyarrhythmias, and this is probably the neuromuscular condition with a high risk for sudden death. You have event rates of 5 to 10% every year, so the risk of sudden death is extremely high. And this is a very arrhythmogenic condition with arrhythmic events occurring really early in the course of the disease, often when patients have a normal cardiac echo, normal echocardiogram, and sometimes normal cardiac MRI. So arrhythmic events occur really early, so it's very important to discuss the indication of an ICD early in the course of the disease. Laminopathies are the first conditions for which it has been shown that implanting early an ICD can be beneficial, and a number of tools have been developed to estimate the risk for patients to have arrhythmic events and to guide prophylactic implantations of ICDs. And the most recent algorithm has been developed by our group. It can help measuring really accurately the risk at 5 years for patients who have a sudden death or malignant ventricular tachyarrhythmias. And you have a kind of calculator. You enter a number of parameters, the patient sex, the type of mutation, the ejection fraction value, whether patients have conduction defects, and you have an estimation of the risk at 5 years of events. And now there's a global consensus to recommend systematically an ICD in patients who have a risk at more than 10%. And there's a number of other conditions at high risk for sudden cardiac death due to ventricular tachyarrhythmias. So in conclusion, the most important message is that patients need to be seen repeatedly for an early diagnosis of abnormalities, to repeated risk stratification for heart failure and sudden death. And you have several different patterns. The first one is the DM1 with a high risk for conduction defects, where I need to discuss the implantation of pacemakers prophylactically, and it's pretty much the same for DM2. I think Benedict was one of the first to show that DM2 patients are also at risk for cardiac complications. And also in patients with mitochondrial disease having single large-scale deletions. The second group is the group at high risk for heart failure, mainly due to dilated cardiomyopathy, such as in Duchenne muscular dystrophy. And in other conditions at risk, you probably need to treat early with heart failure treatments. And finally, you have the group of arrhythmogenic conditions, such as laminopathies, and there are many of them, embryonopathies, desminopathies, FHLN1, and other myofibrillar myopathies, where you need to have an ICD implanted in high-risk patients, no pacemaker ICDs. Thank you for your attention.
having, as usual, a super talk on this so important topic. Are there any questions regarding cardiac issues? Here you have really one of the world experts with you. He has seen so many of these patients. Please.
Hi, thank you very much for the informative talk. My question is, I'd be interested to know if you have any experience using GLS, measuring GLS on routine echoes, especially in boys with Duchenne muscular dystrophy. And if you've been using it, do you see any pattern, or do you use that as a marker to titrate treatments in those boys with DMD?
Yes, sure. GLS is a measurement that can be made on the echo or sometimes on cardiac MRI. You measure left ventricular contractility, but also right ventricular contractility, and it's probably a more accurate tool to diagnose contractility abnormalities. So it has been shown in several studies based on the echo or on cardiac MRI that it's a good predictor of further decline in left ventricular ejection fraction. And I think it can help make decisions sometimes to initiate a treatment in conditions at high risk for heart failure. In DMD, in young kids, it's quite easy to have GLS measurements. In patients with more advanced disease, it's quite often very challenging, and it's very promising on cardiac MRI. It's probably one of the most interesting things to monitor in innovative therapies trials because it's really sensitive.
And is the GLS useful in other neuromuscular conditions where there is predominant cardiac involvement? Because most of the studies on GLS is all from the Duchenne muscular dystrophy boys, but have you found it to be useful in any other conditions, neuromuscular conditions that affect the heart?
Yeah, I think it's pretty much the same in LGMDs, in sarcoglycanopathies, in FKRP patients. We don't have the same numbers, but we have preliminary data suggesting that the place of GLS is probably very similar to that in DMD.
One more, please. Yeah, please.
Hi, doctor. Thank you very much for your talk. My name is Dr. Ura from Chile. I would like to know, in your center, patients with myopathies such as dystrophic myopathies, myotonic dystrophy, when they develop heart failure, are they eligible or candidates for heart transplants, or they are excluded for having a myopathic condition?
There are very few DM1 patients who progress to terminal heart failure and who requiring cardiac transplantation. It sometimes happens to patients who have a very advanced disease, they have a pacemaker, they are permanently paced, but it's really uncommon. But to answer a question and to give a broader perspective, in patients with myopathies in general, I think cardiac transplantation can be discussed when you have an absence of severe respiratory failure, because otherwise it doesn't make sense to have an open heart surgery if you have severe respiratory failure. And the second aspect is the severity of muscular involvement. I think there are very, very few patients worldwide who have been transplanted if they have the permanent loss of ambulation. Because there's a strong competition for the heart for cardiac transplantation. We know that rehabilitation programs can be beneficial in patients who have a cardiac transplantation. So if you have the choice to offer transplantation to a patient that can walk and can have a proper rehabilitation program versus a patient who is wheelchair bound, So, but otherwise, I think there's no contraindication to having a cardiac transplantation done.
Thank you very much.
So I have here one final question online. So how will exercise prescription change in children with cardiac involvement in Duchenne muscular dystrophy? And what about absolute or relative contraindications or precautions for physiotherapists to consider?
Well, we have the global idea or speculation that exercise can sometimes be have a deleterious effect on cardiac function because you increase myocardial injury. We have preclinical data supporting that in dystrophinopathies, but in other conditions such as laminopathies. But on the other hand, we know that rehabilitation, exercise are also beneficial, and patients who are too sedentary have worse outcomes. So we need to find a balance between avoiding having patients with a total lack of activity, and on the other hand, avoiding having patients doing too much sport. So it's not always easy to find a balance, but I think it's the global idea.
So thank you very much. So we've done with this, and now